And if not, then how do we decide? And that's the most important thing. So let me decide to tell you about imaging and how acute coronary syndromes is classified. If you look at acute coronary syndromes and you see the classification of acute coronary syndromes, you have one is a disrupted a plaque or a fibrous cap with an underlying plaque which is lipid, and that's called as a plaque rupture, and that's how it looks like. That's the plaque fissure, the cavities, the lipids have been released. This is a classic plaque rupture which happens in 80% of myocardial infarction. Then there is an underlying plaque, but that is calcium, and this protrudes into the artery and creates a problem. And this is how that looks like. That's the calcium, and the thrombus forms on that. And there's a third, this is a very small number of patients, about 2 to 3% of patients. There's a third group of patients who have an intact fibrous cap with thrombus which is definite, with an underlying plaque which is called as definite plaque erosion, and a probable thrombus plus a irregular surface which is called as a probable. And this is a typical plaque erosion. You can see the clot sitting, no rupture unlike this. And this is a scenario which is seen in young patients. Many of the presenters showed this. And there are other causes which are important, which is SCAD, which is typically seen in women, which can present with myocardial infarction, where you should not intervene in the vessel and leave the patients alone in medical treatment. Now, let's go to the first case, and this is a case where I'm not sure what the angiogram is running, but what it shows here is a typical stenosis in the LAD with which has a plaque rupture, and in this is a no-brainer. This patient needs a PTCA and a single stent, and this is a clear-cut what we do day-to-day practice. Here's another patient. Comes in with anterior wall MI, which was lysed outside. You can see some haziness here. You look at the OCT, no plaque rupture, just clot sitting there. This is a plaque erosion and a definite erosion because you can see thrombus, you can see no cavity behind, no plaque giving way there. So this is a definite erosion. How do you treat this patient? Simply with medical treatment, like how my colleague showed last. So this is the OCT which you can see the thrombus sitting there. There's nothing. The lumen is very good. This artery is not going to close on you, and all you need is medical treatment. This is another patient where you can't see the back of the vessel. You can see the thrombus, but I can't see the black. So I'm not sure whether this is an erosion or rupture, but it's most likely to be a probable erosion. And in the longitudinal thing, you can see clearly there is no fissure or no plaque rupture. This is a probable erosion. So we put this patient on aspirin, warfarin in this situation. These were early days, and we were not sure how these behave. And 6 weeks later, you can see that the entire vessel has cleaned up. There's very thin thrombus left, which is organized. And this is a clear erosion, which is cleared away with simple one antiplatelet and warfarin. This patient is safely left on medical management. This is another patient who came in with an angiogram which shows an RCH stenosis, and here you can see here that there is a calcific nodule protruding inside the artery. I'm sorry, the angiogram is not running here. It was running previously. Anyway, what it shows is a simple calcified nodule. This is another patient where you can see a SCAD, which you can see here. This is a lesion which clearly has a dissection in the LAD, and you can see in the eye was a SCAD. This is a 50-year-old lady. You should not touch these patients. They have to be left on medical treatment. SCAD should not be interfered even with a wire in these patients. This is a spontaneous coronary artery dissection. I'm not sure why these angiograms are not running. Can somebody help me with this? Okay. Anyway, the OCT is showing clearly on the left side typical what we call as lotus stem appearance, and this is typically a recanalized thrombus which is very, very clearly seen in this patient. So these patients are again very important patients that you have to be careful with. These flows are good in these patients, lumens are good. If you try to interfere with the wire in these lesions, what will happen, you can close the vessel on you. So before you interfere in these vessels, be sure that you can get your wires safely across. If the flows are good, again, treat these patients very typically medically. So this is a recanalized thrombus with a microchannel, which is typically called as a lotus stem appearance. This is another interesting patient, came with non-STEMI. He's a strong smoker, family history of CAD. And you can see in this angiogram clearly that you can see the flows are brisk here. There's a lesion in the proximal LAD, right from the ostium. You can see the septal there. But the flows are very good. And this patient was treated just simply medically with dual antiplatelets, high-dose statins, ACE inhibitors, and low molecular weight heparin. And he continued to have medical treatment for this. You also saw the thrombus in the septum. After 2 years, this patient presented again with non-STEMI. And now what you can see very clearly is the lesion is not so much in the proximal LAD, it's in the distal LAD. It's in the mid-distal LAD before the, so the lesion has sort of moved from the first lesion to the second lesion. And if you had stented it, you would have put a stent proximal to what's happening now. So it's very important to understand that plaques progress, plaques change, and there was a proximal ectasia with a lesion which was more in the mid than the proximal what we saw. So again, we plan for antiplatelet. This is what we do. If the flows are good, lumens are good, the angiogram is having TIMI brisk flow, we don't touch those lesions immediately. We just give them medical treatment, heparin, low molecular weight heparin, antiplatelets. And we also do this profile for these patients now. And this patient had a homocysteine which was high, but everything else in terms of lupus anticoagulant, lipoprotein A, everything was negative. And this is a standard protocol we follow in the hospital to look for procoagulant systems. And you can see after the anticoagulation therapy that there's still a lesion in the proximal LAD at the diagonal level. And you can see here there's a lot of thrombus still. This is just a few days of anticoagulation. But clearly good lumens, and the lumen is MLA is 6.8. These vessels are not going to close on you. So just treat these patients like somebody said with one antiplatelet and anticoagulant. You can use Noax or warfarin. So this patient had a rivaroxaban, dual antiplatelets and statin, and then rivaroxaban and single antiplatelet after that with high-dose atorvastatin. Because of homocystinemia, he had folic acid. This is another interesting patient. He came with non-STEMI again. Overnight he improved. The angiogram was done in the morning. And you can see a very, very hazy looking lesion here. You don't want to interfere with this at this point of time. The flows are good. Everything is good. Terafiban, dual antiplatelet. 48 hours later, OCT shows thrombus. This is clear-cut erosion with a thrombus with good lumens, 9 millimeters square, no need to stent. Put the patients on medical therapy. So here we use warfarin, antiplatelet for 1 month, and then warfarin and single antiplatelet. And you can see 6 weeks later, you can't even see if there's a lesion there. Everything is cleared, and the artery looks absolutely pristine. And you look at this OCT, just very minimal thrombus left behind, everything else looking perfect in this patient. And this is a 3D reconstruction of that OCT. You can see the large thrombus before and after everything is cleared with medical therapy. So clearly what this is showing is that there's a group of patients who have erosions who can leave very safely alone on medical treatment. This is a 28-year-old gentleman, came with anterior wall MI, and you can see in this angiogram, there's an occlusion here in that LAD, but there's also a haziness here in the proximal LAD. And that should make you suspect as what is your culprit lesion. So you may be tempted to go and balloon this and finish off with possibly that being the cause. But you should suspect that this is the ruptured vessel and the thrombus has gone down and blocked the vessel. So this could be two pathologies. One is a proximal rupture, clot, and the clot going down and blocking the vessels. So what do you do in this situation? We give lysis with retiplase. We used to have the clearway catheter before, but now we use infusion catheter by puncturing the balloon and giving infusion of retiplase or any thrombolysis you want distally. And this is how you give the perfusion. You put the balloon right there. You can see the balloon there, and we put it right there and give a perfusion of retiplase 5 units through the catheter. After that, we finished the lysis, just left the patient alone, and you can see the flows are gently coming back. Post-thrombolysis, you can see there is some residue. It's a nasty, dirty-looking lesion or pull of thrombus. Leave the patients alone. The patient was brought in for the angiogram next day, and you can now see the vessel is all cleaning up here, but there is a proximal lesion pretty critically here. You can see this. So this has to be interrogated, as that's possibly the culprit, and that's what we do the OCT for. This is again, you can see after 6 weeks of just a single antiplatelet and anticoagulant, the whole thing has cleared out, the distal part. So this was just thrombus which was blocking. And now you look at the proximal vessel, and you can see clearly that there is a ruptured plaque, but no flow-limiting lesion, again with good lumen, so we decided to treat. So even with small ruptures, you do not need to stent the vessel if your lumens are big. So young patients, large proximal thrombus with distal embolization, you can give lysis with distal lysis to a catheter. Oral anticoagulants with single antiplatelet dissolve the thrombus. There is large lumen in the proximal part, and we do not need to do anything for that. Finally, I'll show you another lesion which came with ACS, and you can see that the LAD is definitely hazy, but the flows are good. You can see in this view clearly that you can't use functional testing in ACS to check the severity. So many of these patients we just leave on medical treatment after. So this patient had again an OCT, and you can see good lumen, thrombus, just medical treatment. Do not put a stent in this patient. He also has a circumflex lesion here. It's a nasty lesion. Do you need to do anything? No. Leave the patients alone. Bring them back later and check, and after 6 weeks, a functional test both for the LAD. So you can see the LAD FFR, now the ACS has settled down, is 0.99. The FFR is 0.79, very borderline, in which case you don't need to interfere with the LAD. You look at the circ, you'll be tempted to put a stent. You do an IFR, 0.97, FFR, 0.84. 5 years down, patient is on antiplatelet statin, no problems. No stent required for both vessels. Patient presented with ACS, treated medically. So many of these patients, you don't need to interfere if there is no flow limiting, problems. And when you, especially on imaging at the acute state, has good flows and good lumens, and later on you do your functional testing, and you can leave the patients on medical treatment. Where is the evidence? This is the first study, erosion, which was done by I.K. Zhang and a lot of Chinese colleagues, which showed that a 1-year follow-up of OCT demonstrated a decrease in thrombus volume in plaque erosion patients with aspirin and ticagrelor without stenting, and had no major MACE events. So you can safely leave these patients with erosion on dual antiplatelet. This is the multi-center randomized trial which was published last year, which was again in JACC cardiovascular interventions with OCT-guided reperfusion versus angio-guided reperfusion. Finished 1-year follow-up, no difference in outcomes. More stents implanted in the angiographic guided arm than the OCT guided arm. So you're putting in unnecessary stents, which will cause problems in the long run. At 1 year, no MACE change. So what in conclusion I think we have to understand is that plaque erosion is a different animal. It's a different pathology. SCAD is a different pathology. Calcified nodules are different pathologies. What should dictate whether they need a stent or not is one, what is the pathology? Is a large rupture, huge flap, is going to close the vessel? Well, you need to fix a stent. All others like erosion, SCAD, medical treatment is good enough. And if you can do an imaging, you can prove that this is the right way to go. Thank you very much.